So when we talk about comorbidities, I like to describe what's happening at the hormonal level to explain the sign and the symptoms that we have with PCOS. What happened basically is an increase of male hormones as well as an increase of insulin. That's the two main hormonal dysregulation. And that is bring with the genetic factors, but also with the lifestyle. So if you have increased androgen, you have all the signs and the symptoms that we see with increased male hormones like hirsutism, acne, increased lipids can be present also, and you can have anovulation, which means you don't have regular secretions of the progesterone each month. Also, if you have increased insulin, you can have the anovulations, and you can have increase of metabolic problem like diabetes, high blood pressure, cardiovascular disease. It really affects the mental health by creating more problem with self-esteem, depressions, anxiety, but also eating disorder like anorexia and bulimia. So now we'll discuss the other disease linked with the PCOS. One of the first one is diabetes or intolerance to glucose that we can see in 60 to 70% of patients. And there is 4 more times to have diabetes in America if you have PCOS. The other one is increased lipids that we can see in 70% of patients. And also if you have a combination of high blood pressure, diabetes, obesity, mostly the abdominal obesity, and increased lipids, it's what we call the metabolic syndrome, which is present in 43 to 46% of patients. And metabolic syndrome is really linked with an increased risk of cardiovascular disease. Other factors as well can affect cardiovascular disease, and your doctor will ask you exercise, family history, if you smoke or vape, alcohol consumptions, your stress. One of the major risks that we want to prevent is endometrial cancer. In patients that have PCOS, we know that it's also common to have really prolonged and heavy bleeding when you don't have regular bleeding. Why is that? If I go back to the cycle, the first part of the cycle, it's where your estrogen go really high and prepare that layers where the embryo will implant. The layers we call endometrium. So it's getting thicker and thicker, and when you have ovulations around mid-cycle, progesterone is secreted and it helps to stabilize that layers. If there is pregnancy, progesterone will be still produced and eventually by the placenta, and it won't have any bleeding. But if there's no pregnancy, progesterone will go lower and it will induce what we call a withdrawal bleeding, where you shed that endometrium. If you don't have ovulations and you don't have the progesterone, it means that you always have those proliferations of the endometrium, so it's getting thicker, thicker, and thicker, and it can eventually start to bleed uncontrolled and heavily. As well, you can have irregular cells or even cancer that develop in that layers. So in any suspicions, healthcare provider will talk to you about getting a sample of the cells of that endometrium to be checked and make sure there's no abnormal cells. But any patients who have really irregular cycle, heavier bleeding, obesity, or family history need to have that sample done. If you have polycystic ovarian syndrome, you have 6 times the chance to have endometrial cancer. When I explain all that to patients, I like to have the analogy with the lawn. It's like you have your lawn and you put fertilizer on it. The fertilizer is like the estrogen, so it grow and grow and grow. And if at some point you don't stop, you can have some weeds or abnormal cells. The progesterone would be like the lawnmower, and you go over it and get rid of that layers.